my attendees out there, I want to thank PreXion for hosting, I think, this very, very important webinar. And yes, we're going to be talking about right now where we are. We're in April when I'm doing this specific webinar. And it's really about treating emergencies in COVID time. I'm running a vlog called The New Norm. This can be seen on Catapult Education and Midway Dental. And I have to tell you, this has been the strangest time in my career. There's absolutely no doubt about it. I've been practicing 35 years. I've gone through a lot of unusual phases. This is the most unique. And openly, I want to tell everybody out there as I get into this, I think we're going to be facing a more unique challenge as governors open up borders, open up guidelines. And I am very, very concerned about all this. So with that being said, I think this course is really appropriate, and I really all hope you find the great value in what we're about to share. So let's start with what we understand about COVID, because this is going to guide my screening and my testing and how openly we should be trying to be as safe as we can in our practices. So this is what we think we know, because this all keeps changing. The studies really have come out of Iceland. They're the most tested country in the globe. Over 10% of the population has been tested versus less than 1% in the US. But this comes out of the CDC, and it says up to 40% of all those patients who've had the virus had very little symptoms, if any. So most of them didn't even know they had COVID-19, which means when they're walking into your office, they could be asymptomatic or mildly symptomatic. And it becomes essential for you to protect you, your team, and your patient and all the families related to all. Incubation averages about 3 days. It can go up to a week to 10 days, but the studies go, it's about 3 or 4 days, okay? 3 or 4 days before you start seeing symptoms. Once the symptoms start happening, people can be contagious, understanding even before the symptoms in this incubation period for a couple of days. This is the scary part of this. So they can be contagious before symptoms. In regards to symptoms, the milder cases become less contagious approximately 5 days after the symptoms disappear. This is all part of questioning the patient. Severe cases, have they been hospitalized? Were they really badly ill? These can be contagious up to 4 weeks after. So the scale of the disease or the virus and how it took over that patient becomes openly how contagious they may be to other people from 5 to really 4 weeks after their symptoms disappeared. So a lot of this has really come out of more what the data has shown. If a patient has the symptoms, they should absolutely, every one of them should be quarantined for an additional 2 weeks after the symptoms have disappeared, not just when they're sick. Don't be going out to the grocery store as soon as your symptoms are done. What they need to be done is they need to be still in quarantine 2 weeks afterwards and then tested for the virus to see has the virus stopped shedding. Now, out of Italy, what they're doing is they're keeping the people in quarantine 4 weeks after the symptoms and then testing them. And I love this, because what they're doing is they're maximally trying to be protective, and you're going to see this relates exactly to my guidelines. What we also know is that sustained contact is the #1 way this is transmitted, whether it's in a home or way too many people at Mardi Gras or people in a nursing home via sustained contact, or at the workplace with sustained contact in a closed room where 5 or 6 people are in an office, or in a factory in South Dakota or North Dakota, wherever that was recently. So if we know the primary form of transmission is hand to mouth or eyes or nose, and we're going to get into this, we also have to understand that breathing, and aerosol have now been confirmed. So this is why dentistry is so in the front line of this whole thing, because this can easily be transmitted via breathing or aerosol. Yes, this is a very easy virus to kill outside the human body. We all know that. We all know it's, but again, it's also highly contagious. So the CDC, in preparing their guidance, you know, I'll say their guidance on workplaces, has rated dentistry as the highest risk. A dental office, hygienists, dental assistants, front team members are at the highest risk because of aerosol and breathing. So our guard has to be way up, way up. And this is really when I didn't follow my parents' advice. So this is from the New York Times. This is humbling. This graph is based on an XY axis based on the left, exposure to the disease, and then proximity to the disease. And as we are exposed to the disease and come closer to the patient or the individual, we are most exposed. Look where dentists are. We are at the top. Now, don't misunderstand me. Are paramedics exposed? You bet. Flight attendants? You bet. Personal care aides? You bet. Nurses? You bet. Police? All of these people have come down with the virus. They are in a high-risk category, and you're going to see why that's important when I go through testing and advice and screening. But look where dentists are, and look where our team is at. We are at the top of this curve. Great. I should have been a lawyer. So this is how I see it going forward. You got to minimize risk by doing advanced screening. You got to do advanced screening. I'm going to walk you through this. Then you got to do advanced testing. And then after we do these two things, now we can adopt new guidelines through OSHA on how to minimize aerosol issues and maximize our safety. So it's a 1, 2, 3 approach. This is not, hi, I just need an N95 mask. Give me a break. So in screening, the idea is when you send out a screening tool or a screening questionnaire, you want to determine, is the patient no risk, low risk, medium risk, or high risk, or in fact, very high risk. So let's talk about the new norm and advanced screening questions. This is critical for everybody listening to this. Now, if you would like these questions, I can supply these questions as a questionnaire out to PreXion, and they can distribute all of these questions. And this is on our questionnaire that goes out to all of our patients. So the standard question is, do you have respiratory issues, fever, cough, or headaches? Fever has been shown to be in 87% of the patients. Cough is in 67% of the patients, and then it goes down. Patients have also noted a change in their ability to smell or taste. Okay, these are standard questions. So if you're asking somebody this and they say, oh yeah, I've had a low-grade fever and I've been coughing for 3 days, well, you have to assume that they're high risk. If they say no to these questions, if they say no, they're at a lesser risk. But please remember, what did the CDC and the studies out of Iceland show? 25 up to 50% of all COVID-19 patients are asymptomatic. So they may not have the symptoms, they still could be carrying it. If they have these symptoms, what should they do? They should contact their doctor. As a dentist, we should offer palliative therapy over the next 4, 5, or even 6 weeks until they're tested negative. These are the patients at very high risk. So if someone comes in and says, no, no, no to all this, and they enter your office and you do a temperature test on them, which we should all be doing, and they have a low-grade fever, out the door. We don't want them in our office. And we should be testing them in our office when they're wearing a mask, even initially with our temperature or, you know, our new way of doing this. Question 2, have you been around any individual who's had these symptoms or tested positive for COVID? And if so, how long's it been? Well, let's go back. Let's understand why this is important. If they haven't been around anybody with COVID, then they're lower risk. But if they have been, and the incubation period is up to 10 days, normally 3 days, if they've been in contact with anybody in the last 2 weeks, my feeling is they should get a COVID virus test. And that we can offer in the office, and we can currently send out and get it back in 2 days, or we can send it to their home. Additionally, I would offer an in-office antibody test, so I would be double screening them. That's how I look at it. Now, if they were with somebody 2 weeks ago, 5 weeks ago, 8 weeks ago, and they've been in home isolation, they're already through the incubation period, I see them then as a lower risk, but I would still want to be just testing them with an in-office antibody test just to make sure. And you'll see if they have the antibodies. Question 3, have you traveled lately by car, plane, train, or bus? And have you traveled in car a long distance? Because if they're just going to the grocery store to do food shopping, we ask them this: were you wearing a mask? If you're on public transportation, a bus or a train, were you observing social distancing? Were you wearing a mask? I mean, if someone's taking a bus to work every day and they're on social, and they're on transportation and they're not socially distancing and not wearing a mask, those people are high risk. The same with a plane. Did you get on a plane and was there social distancing and were you wearing a mask? It's the same concept. This all guides you to whether they're low risk, medium risk, or high risk. If all they've done is get in their car in the past month to go local food shopping and wear a mask, I consider them a lower risk. If they've been on mass transportation within the last 2 weeks, sorry, I would recommend a COVID virus test and an antibody test, because these people are at medium to high risk. Question 4, does your job require you leaving your house? That's if you have a job. I don't have a job. Maybe they do, but do they have a job? If no, they don't have to leave their house. They're obviously at a lesser risk. But let's say they say yes. If they say yes, then you're going to want to know, does your work involve a higher risk environment? What does that mean? Are they working in a hospital? Are they a paramedic? Are they in a senior assisted living center? Are they doing childcare? What is their point of contact? Like, are they a cashier? Are they a transit worker? Are they in the civil department, like a policeman or a fireman? All of these people are at higher risk. We've seen the fatalities on the nightly news. If you know this is their job, that's one thing. If this is not their job, they're a lower risk. If it is their job, you're going to want to recommend a COVID virus test. You want this, and you're going to offer an in-office antibody test. This is how you're protecting yourself. Now, they may have already had a test, and then you're going to want to know, when was that test done? If it was done a week ago or 2 weeks ago, does that make you comfortable enough? Or are you going to want to retest them, and no matter what, you're going to offer them an antibody test at the office? Again, higher risk, medium risk, low risk, based on their work. Are you working outside the house? And now you're going, are you involved in meetings that have 2 or more people in an enclosed space, like you're in meeting rooms? And are those people wearing masks? Enclosed meeting spaces have been shown to present challenges. So whether really with or without masks, if they're in meetings for hours at a time, I would be getting a COVID PCR test and an antibody test. These people are medium to high risk, because yes, they may be practicing social distancing, but they're involved in meetings and within closed rooms. That's our biggest concern. Now you'll ask question 7, are you yourself practicing social distancing, and are you staying at home? If the answer is yes, they're a lesser risk. We know that. Oh, you haven't done anything for a month except go to the grocery store? They're your lower risk patients. If they're not staying at home, if they're not practicing social distancing, they're high risk, period. And you know what you have to do? You have to COVID test them with a PCR test and offer them an antibody test. Then you have to ask the next question, is anyone living at home with you? Do you have, and again, are they living at home? Do they have, is it a husband, a wife, a partner, 3 kids? Now you got to go through the questions on each person. So if it's your husband, are they social distancing? Are they going to work? Have they traveled? Same thing with your kids, your cousins, your mother-in-law, your mother. All of this has to be done because what you're doing is trying to figure out the risk factor of that patient coming to see you for an emergency. And then another question, which is number 9, when was the last time you were in a setting with 2 or more people outside of your home who you're not living with? So again, these are guests who you're seeing, whether in your home or out of your home. Okay, you could have gone to their house. When was the last time you did that? If not within the last 2 weeks, they're at a lesser risk because the incubation period is really up to 10 days. If they say they've been in a social setting with 2 or more people within the last 2 weeks, you're going to have to ask questions about those individuals who they were hanging out with. Were they practicing social distancing? Were they staying at home? And that's going to guide you to what you're going to do. Depending on their answers, you're going to have to decide, do I have to give them a COVID PCR test? And in addition, an in-office antibody test. Again, understand the more interactions, the more risk profile. And as people start now going out of their houses per what phase 1 or phase 2, I am telling you all these questions are going to be critical. Question 10, have you had a recent COVID test? You're going to want documentation. They may have had an antibody test. You're going to want documentation. This is your ideal patient. If they've had a COVID test and they're negative, and they've had an antibody test, and hopefully they're positive, which means they've been exposed and now they have the IgG antibody, that's the best possible patient. But you're going to want documentation if they say they've been tested. Otherwise, they could be lying. Then you're going to ask, have you had the virus? You're going to come into contact with those. Okay, now the key question is, how long? How long ago? If it's been less than 4 weeks, they should still be in isolation. So if you go, well, when did your symptoms disappear? Oh, 10 days ago. You're not going to see them. They're uber high risk for shedding. You want to wait at least 4 weeks after their symptoms have disappeared. You want to wait at least 4 weeks. If a patient is at a 4-week time period now and they have the symptoms since they've disappeared, in other words, the symptoms are gone, and they haven't had a COVID test, you should recommend a COVID virus test. Why? You want to make sure they're negative. Then you want to offer an in-office antibody test to see if they have the antibodies. This is your double way of knowing. If a patient had COVID 5 weeks ago, 3 months ago, and their symptoms have obviously disappeared long ago, 5, 8 weeks ago, you're probably just going to want to recommend an in-office antibody test to see if they have the antibodies. These patients should be considered low risk. So here it is. A patient who's had the virus 8 weeks ago, I consider low risk. You want to antibody test them just to make sure to see if they have the antibodies. It sounds counterintuitive, but if everybody had the virus already, I don't think we'd be having these issues. So what if a patient says they're all no's? I don't interact with people, I'm not travel, I've been at home 3 or 4 or 5 weeks, I'm doing social distancing. I'm probably going to do an in-office antibody test. I look at these people as low risk. So those are my really screening questions. So I'm going to take you now to a patient that we're actually seeing Monday based on her emergency. And I'm going to walk you through how to manage it in COVID time, so to speak. We'll call her name Joanne. She's 57 years old, and she's got a history of breast cancer in 2013. She had a previous history of blood clotting, and she's been treated for that. She's on Arimidex. She takes 1 milligram, and this was part of her breast cancer treatment. She has discontinued Zometa now 2 years. It is a bisphosphonate, and that was part of her breast cancer therapy. And she's on a blood thinner called Xarelto, 20 milligrams. Has not had an INR test done for it. She's been on this since 2014, does not go in for routine INRs. So what happened was, tooth number 12 was treated in February for acute pain. And an endodontist did the root canal and noted there was a mesial distal fracture running through the tooth. She advised the patient to try and save versus an extraction and cornectomy based on the Zometa history. The most conservative would be, let's avoid an extraction. So about 2 weeks ago, it could be 2.5 weeks ago, I get a text, and this is the patient taking their picture, and they have the abscess. So this is the tooth that was root canal. Obviously, there must be a fracture because they've got a perilous. Now, what do you do? So we were waiting for PPE that was just delivered to our office, and we could see about 8 patients this week. But I told her what I was doing was, of course, keeping her on amoxicillin. And again, there's debate whether she should even be on amoxicillin because she wasn't feverish, but she was very fearful. And so because this was localized, that's what she wanted. I put her on amoxicillin. I'm very much anti-antibiotics unless there's a systemic effect. But again, that's what she wanted. I explained that to her. That's what made her feel better. Fine. So what I wanted them to do was, we're now 2 weeks out. She sends me another picture. She's not swollen. Still, the perilous is there. I accessed her chart online to find out what had happened, and I could access her combing because we had taken a combing pre-treatment. So this is the beauty today. With remote technology, I can access all this information. So here's my PreXion image pre-treatment. So here's her scan. And at this point, all I'm doing is lining up my axes so I can visually see tooth number 12. So this is the coronal view, and that's looking front to back for those of you who are not cone beam users yet. And this is what I call the money view for implants. And within this view, you'll see what we can do. We could not visually see the fracture. And a lot of these minor fractures will not be visibly seen on cone beam. People say you can see everything. No, there are still limitations. Using the simple measurement tool from PreXion, we were able to evaluate the width buccolingually of over 8 millimeters and the length at 15 millimeters from the crest of the bone approximately. So there's no question I do not need to do a sinus lift. This is the beautiful part of the measurement tool. It's so easy. You can do this on a 2D x-ray. So with the coronal view alone, I can tell the width of the ridge, the length of the ridge, no sinus lift. I could also see the orientation of the roots. And I knew I would have to be grafting, or my periodontist, when we take out this tooth, we'd have to be grafting because of where we're going to be placing the implant, which I'm going to get to next. So the simplicity with PreXion's imaging is all you're going to do is go up to their implant bar, then hit plan, then hit new. I'm a BioHorizon guy. So, and again, there are many great implants. By taking the measurement tool, I knew that I could go with a 4.6 millimeter wide implant that was 12 millimeters long. So all I do is scroll through the library, click it, and as soon as you click it, it comes in all 4 screens. Now it's in all 4 screens. And as you move it in one screen, the beauty is it'll move in all 4 screens. Now, I believe in restoratively driven implant dentistry. Normally, I'd make a surgical guide. We got to take out this tooth. We don't have time to make a surgical guide. So at the very least, I can guide my implant surgeon on what I want. So I'll just show you some images here. So this is your 3D template showing you the implant, the 4.6 by 12, the BioHorizon. This is your axial view, and you can see it's right in between both roots. You can see where it is between buccal and lingual. Here's the sagittal view. Again, the proximity to both the bicuspid and the canine interproximally. Now I'm going to enlarge the view. And so what you would do, you go up to the tool gauge and hit the enlargement tool. And then you take off the enlargement tool, and then you just go to basically your scroll feature. And once you get trained, this is so easy. You got to love it. And I'm not the surgeon. I'm the restorative dentist working with my surgeon, telling him where I want it to go. And as you can see, this is ideal in my eyes because especially when you look at the coronal view on the bottom left, I know where my screw access hole will be, and I can avoid a cement down. So just enlarged, and again, this is the money view for me. You can see where the screw access will be. The axial view enlarged, and finally the sagittal view. Okay, so now I'm ready to talk to the patient. I have some understanding of what we're going to be doing. I've already had a verbal call with my periodontist. So with all this information in the COVID era, now it's time for teledentistry. Teledentistry, it so fits into today. It really does. The way I best explain it, and I didn't know what teledentistry was in January, but I gotta learn. I'm always learning. So the way I describe it is it's a HIPAA compliant Zoom tool. You can have multiple people on it, and basically I'll walk you through how easy this is. But now when my team does a questionnaire, COVID questionnaire, we're going to be teledentistry every patient. Why? As long as they have access, otherwise we'll do it verbally. And I'll explain that in the sense that when I talk to Joanne and I'm going through her medical history and then I go into the COVID history, these are personal questions. When you're face to face with someone, you can kind of telling you how they feel about answering, and are they telling you the truth? I wasn't worried about Joanne. So personal, I think this is far more personal than picking up a phone. And with our COVID questionnaire, this is ideal. So for those of you watching this, the way I got into this was I went to ICE at midwaydental.com. It's basically $75 a month. And I think I pay $100 a month and I can have all 6 of my doctors use it. I'm just, again, telling you, I have no affiliation with ICE. I am a clinical director I am the clinical director for Midway Dental, and I love this system. So what happens is after ICE sets it up, you will have in your Google account your own, obviously, telehealth environment. And so here it is. My office is University Dental Professionals. On my Google Chrome, I've already saved this as a favorite. And all I have to do is type in, if you don't use it as a favorite tool, you just type in your browser, udpdentistry.icehealthsystems.com. If you're Smith Dentistry, it's smithdentistry.icehealthsystems.com. So as you hit that, this is what will open up. And then you will start a session. And all that involves is when you start a session, this is on your screen where the arrow is, you will see that it says copy link. I leave this as a public session. It's only for whoever you're inviting. And all you're going to do is copy link. And then all you do is you email the link to Joanne. And so all I did was hit copy. And then I went on to Joanne. And before I hit send, all I did was right click, which pastes it. And so now here's her link. It's that simple. Copy a link, email it, just like Zoom meeting. So here I am, great haircut, don't judge me. And I blacked her out or whitened her out. And now the discussions happen. And this took about 45 minutes. Why? Got to go through her medical history. I got to go through her COVID history. She has a husband. I had to go through his history, just like I had talked about. I had to talk about options in her treatment. What were we going to do? We had to take out the tooth, and we were going to graft bone. And if we could, my periodontist will drop the implant in that day. Absolutely. Why should she go through 2 surgeries as long as the bone is there? I wanted her to understand it. Could we have done a bridge, a Maryland bridge? Could we have done a partial? Of course. I gave her all these options. What would I do? I told her I would drop in an implant that day. So it's really a consult. I'm not charging for this one because we're doing the work. There is a teledentistry fee. It's per every 15 minutes. There's a different code for it. And now insurance companies are understanding that. So if I have a new patient, I've got to do a consult, I'm charging for it. These were her answers on teledentistry. She's been at home the entire time. She goes out grocery shopping. She's very careful, wearing mask, gloves. She's a low risk. She's never had symptoms. She's had no contact with anyone who's tested positive. She lives with her husband. I had to go ask the same questions. He does web meetings from his office. Then I ask, who do you see at your office? Her response is, he has no contact with his colleagues. They all go in on rotation, so they don't have to see each other because of COVID. And he's never had symptoms. So what's her risk level? I would call it no risk, but let's call it low risk. So if she's going to come to the office and I can give her an antibody test, I can give her an antibody test to see if there are any early symptoms, which I'll get into. But openly, I'm very comfortable treating this patient based on this. Then what do? I teledentistry my periodontist, Ralph. We reviewed her options, talked about her medical history. He reached out to talk to her doctor about her blood thinner. We talked about current meds, and the COVID risk assessment I went over. So normally my front team would go over this. I just decided to do that. So what's her risk level? And what if her risk level was medium to high? What would you do? Her risk level is low. What would you do on a medium to high? So let's say she was out and she was working at the University of Chicago and she needed this tooth out. What are you going to do? I work by the University of Chicago. What if she was a police officer? What's her risk level? What if she wasn't doing social distancing? What if she was living with 2 children and one was COVID positive 3 weeks ago, 2 weeks ago, 1 week ago? How does that change all this? That's why we screen. So to me, it's all about testing, 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 minimizing risk. And until we have a vaccine, I think testing is absolutely an essential step in our offices. Now, I know what a lot of you are saying. I'm a dentist. Get over it. We're doctors. We are doctors. And if Tim shows this to optometrists, we are taking care of our patients. So it's so important that we understand we want to minimize our risk in our office. And if somebody comes back positive, I don't want to see them. But what's available now? There's really 2 primary tests, and I'm going to take the confusion out of this. And this is going to change. Right now, there are 2 tests. They're offered by multiple manufacturers. One is a PCR virus test, and one's an antibody test. Let's cover the PCR virus test. So this is the COVID-19 at-home test. It is an at-home test. I do not have this at my office. Nobody does. And this test basically analyzes saliva. So it's a PCR test that analyzes the RNA of the virus and basically can quantify how many particles are actually in there in the saliva itself. So the way it would work is in my office, they could come in, and I'll walk everybody through this. They can come and pick it up and then send it out. Or I can even have the company FedEx it or UPS it out to them. The testing itself is very closely monitored, and it is so specific, and this was all based on the SARS-CoV virus, which is in the same virus family. And when I look at the clinical infectious disease reports on testing, just want to highlight a couple things. Hold on, did everybody get to read that? Okay, so let me highlight a couple things. Saliva specimens can be provided easily by just spitting into a sterile bottle. That's how the kit comes. It has a very high accordance rate of 90% or greater for coronaviruses. In some patients, the virus was not detected in the nasopharyngeal aspirate. In other words, sticking that thing all the way up your nose, but only in the saliva. And I think it's really important. I'm going to take a pause here. So here's what they know. When that virus basically enters your body routinely through your nose or your mouth, it is attracted to a specific receptor on a cell membrane called the ACE2+ receptor. Now, what we've been learning about is this ACE2+ receptors in the lungs. That's why the virus goes to the lungs. It's looking for that receptor. So that's a problem. It's also been found to be in the heart. It's also been found to be in the kidney. But what most people don't know about, the ACE2+ receptor, the first place it comes into contact potentially with a virus is in the mouth. And where is it? It's in the epithelial cells around salivary glands. So the studies have shown that whether it's coming through the nose or through the mouth, saliva testing is probably the most accurate because that's where the virus is going to first, to these epithelial cells. So it's been a screening tool around for years for this because it was really seen in the SARS virus era, which is whatever, 9 or 10 years ago, 8 or 9 years ago. Also of interest, just said, saliva specimens not only contain the saliva secreted from major and minor salivary glands, which are surrounded by their epithelial cells, but it also can contain the saliva secretions coming down from the nasopharynx. Of course, it drains. And another interesting fact is It can also be brought up from the lungs via the cilia lining the airway. So again, this is why we're doing saliva testing. And according to an adjunct professor at NYU Dental, the advantage of saliva testing is the larger sample volume. You got more targets. Equally, in this collected sample, you can be evaluating the quantity of viral particles. We still don't know what the minimum threshold is, but we believe the more particles, the worse it can progress. It is likely that if the virus is shedding, you're going to see it in the footprint in saliva. So the bottom line is this is an easy testing kit. It's a spit test. It takes the variables of missed nasal samples. It takes the variables of difficult samples getting the sputum, because what happens is patients develop any lung problems, they can't hock it up. They can't get the sputum. So this really, I find, can really minimize false negatives. That's the key. Let's talk about the antibody test. I know Tim's really high on this test as far as an in-office antibody test and what we can be doing about it. And this test could be available, I'm hoping, this week to, I hope, thousands of dentists and other practitioners. It's a screening tool to see if someone who has been potentially carrying the virus, and they could be carrying the virus and they have been symptomatic or asymptomatic, okay? So it's a very rapid screening tool with a 15-minute data point, 15 minutes. So here's what happens. You're gonna prick somebody's finger, place it in this little, we'll just call it area within the testing kit, mix this specific saline, and you wait. And if you're negative, you see what happens if you're negative. That's what the assay will show. If you're IgM positive, which I'll show you what that means, there's your IgM. You could be Ig positive, that's Ig. You could also be Ig positive, GG positive, and IgM positive. You could be both of them. So negative or IgM positive, IgG positive, or both. So let me explain this. And here's the money slide. Okay. Here's the money slide on this virus. Remember, the incubation period could be anywhere from a few days to up to 10 days. This test will not measure the incubation phase. I believe the PCR test can, if you've got viral particles starting to shed before symptoms, I'm hoping that's what the PCR test is giving me, that additional information, okay? Or if you've had the virus, the PCR test, or haven't, it's going to tell you and you're still shedding. Let's talk about this antibody test. Look what happens in the first 7 days. You may have fever or you may not. We don't know. Again, up to 50% of the patients may not have any symptoms. Well, what happens is IgM, that antibody, starts to go boom right up in 7 days and peaks around 7 to 10 days. The IgG antibody starts to kick in day 7. They cross over between day 7 and day 30. And after about day 30, all you have left is the IgG antibody. So if someone comes in and they've had a history of the virus and they have Ig antibody, they have at least some partial immunity as we know it now. We don't know how long. If someone has the IgM on the test, I don't want to see them. I don't want to see them, because that means they're still active. I do not want to see them in my chair, and we're going to have to let them go. We're going to do palliative therapy. That's how this test really helps guide us. Got it? Got it. So how accurate are these tests? The test has been shown to be 88% or 88.66% sensitive. So what that means is when they tested 352 people who they knew had the virus, or 397, 352 tested positive, 12% tested false negative. False negative. On specificity, which tests the people not having the disease, it was 90% specific. Let me explain that a little bit more. Okay, sensitivity, we want everything to be 100%. Good luck on that. But sensitivity is the ability of a test to correctly identify if they have the disease. So we're evaluating the COVID virus disease. In this case, we knew all the patients being tested had it, but 12 missed it. They got a false negative. In other words, they just You don't have the disease, but they actually did. Okay, that's the sensitivity. Specificity means we knew X number of patients didn't have the disease. So 10% of them basically were told a false positive that they had the disease. So understanding sensitivity and specificity, this is why I think this is a good screening tool. And it says in their directions, this is a screening tool. It should not be the only basis for diagnosis. That's why we screen, we ask questions, we take temperatures. We're asking questions, look at your patient, talk to your patient. And even they say other testing methods could include a PCR test, which is what we talked about previously. So if the screening questions places them in a medium or high risk, you're going to want to do a COVID PCR test to minimize any risk in addition to the antibody test I just showed you. Okay, so now take a stretch. Okay, now the new morning huddle is nothing like what I used to do in my morning huddle. In my old morning huddle, I would talk about what do we have to finish from yesterday, what kind of paperwork, what kind of referrals. Then we talk about today, what are we doing today, what are our patients coming in for, and then we talk about tomorrow, what do we need to prep for tomorrow, be a 15 or 20-minute huddle. Now, what we do is the new morning huddle, it's totally different. You're going to be looking at 1 week ahead. You're scheduling your emergencies routinely 1 week ahead. And what are you looking at 1 week ahead? You're going to send out a questionnaire to that patient 1 week ahead. Your front team will contact that person, and there'll be one front team member who's going to follow up with that patient. And that front team member is going to request time for a verbal, a call, or a visual review of the form, which is teledentistry. So I've designated one person who I've trained to go through the questions. After that person reviews the question, the information then is transferred to the doctor. In other words, they're going to call the doctor and review it with the doctor. The doctor will determine what tests need to be done. And this may necessitate the doctor calling the patient going, this is why I want to do a COVID test, or this is why we're doing the antibody test, or both. So openly, first question somebody will say is, what happens if they don't want to take your tests and you think they're medium to high risk? I'm not going to treat them. I'm sorry. Why would I put my health at risk because a patient refuses to be tested? They can go down and see the next guy down the street who's practicing like he was practicing in 1985. I'm not going to put myself at risk. Say no. Stand tall. So for microgen DX testing, which is the PCR test, this is what happens. The patient would come to the office and basically text us. We use Weave. We love Weave. And they would text us that they're there, and we would meet them outside the door, give them the kit, and off they go. We would ask them, and there's other ways to do this. We could leave the kit right outside the door and have them just pick it up, and we don't have to see them. Or if they want to come and pick it up, they have to be wearing a mask, and we'll be wearing a mask. Every step is important. And the patient, if they want to come in, the patient will be told to wear a mask. If the patient cannot pick it up, I'm going to overnight this PCR test to them. They'll pay for that fee. The patient will just basically spit into the saliva. We can show them a video of it. And basically, they're then going to send it to the lab. And I want them sending it to the lab 3 or 4 days before their appointment, so I know if they're negative or positive. And I'm telling them, continue to social distance. If they test positive, I'm not seeing them. I'm just not going to see them unless there's something so urgent that I may have to then see them at the end of the day when there's no other patients, and we'll figure that all out as we go into the new norm. If they're negative, they're also going to take an antibody test. The day before they come in, my team will call them up one more time and review the survey to make sure there's been no changes. I think this is a key point. You want to review the screening the day before. Oh, you went out and did shots? You went out and did shots last night at your friend's house with 9 people? I think that just changed how I'm looking at you as a patient. If they are deemed low risk and you want to only recommend the antibody test, we'll tell them to arrive 15 minutes before their appointment. We're only going to have 1 chair in the waiting room for the next 6 weeks because we're just going by these safety guidelines. Well, let them wait there, and there'll be nothing in the waiting room to read, so they, period. And we don't want them even on their phone. I don't want cross-contamination. Well, part of our protocol is when they come into the office, they're putting their phone in a Ziploc bag. Yep. There'll be one designated team member tracking each and every patient to make sure the screening questions and testing are all being followed. So in the morning, I want to make sure if we're seeing 4 patients, what are we doing on all 4 patients? Have they been tested? What's the testing? What are we testing at the office? And briefly, I'll just say this, the ADA needs to change this. The ADA sent this out this week. Dentists cannot diagnose COVID-19 or COVID-19 immunity, which means the antibody test and or the PCR test or both. But they can perform physical examinations of patients. Gee, thank you so much. Which includes ordering or doing the lab test, but I can't diagnose it from the lab test. Here's what I'll say, give me a freaking break. This is ridiculous. I'm a doctor. If when you do a PCR test and it comes back on a portal and it says positive, it's positive. It's negative, it's negative. I'll have a COVID release form. I'm not responsible for the testing. I'm just responsible for interpreting the testing is how I look at it. They're telling me the answer. So my feeling is I am going to be doing testing, and I know that may not be what my professional regulation wants. Too bad. This is about my team safety, my patient safety, and my safety. The AGD, on the other hand, Connie White, kudos to Connie. What did she do? She and the AGD sent a great letter basically telling the state legislatures, each state, why we should be testing and why we should be putting our final results in or our results into drug monitoring programs so we can start to nationalize the results. I say kudos. This is exactly what we should be doing. Could this protocol change, this lab testing change? Of course. Just this week, new saliva tests are coming out, and they could evaluate the saliva in 30 minutes. I may want the patient to come in the day before. Let me know if they're positive or negative. Why? If they're positive, I'm going to want to know the day before. I don't want to know the minute before. I want to know the day before. Now, some offices will just bring them in, and if they're positive, then what are you going to do? Are you set up for this? Are you set up the right way? Again, it's how you want to set the whole thing up. One of the tests would be Abbott's ID Now test, but this is one that was announced 2 or 3 weeks ago. I have no idea how much it's going to be. They say you can get the results in as little as 5 minutes for saliva testing. So let's close this on some additional next steps. Your voice to the patient. I've done this and I really recommend it. Send a text or an email to your patients. Link it to a video. Take a selfie video or have your partner, wife, husband, one of your kids, whoever, take a video explaining your new office policies. I've done this. It's on my Facebook page. Tell them your priority in your video is their safety. Tell them your team's safety is a priority. And this is why you're doing all these protocols. Tell them your screening protocols, why they are so important, why these questions are so important, and expect a call to review these questions or a teledentistry review. Tell them about why you require 1 or 2 COVID tests. Could be the PCR test, could be the antibody test. It may not be any because they may have documentation that they're clean. But again, explain to them why, just briefly, why you're doing certain tests. And tell them your PPE fee. Mine is going to be $20 to $40. It just depends on my cost, and it will go down as my costs go down. Tell them your teledentistry fee. You may charge $50 for the first 15 minutes and say, listen, my time, listen, I instead of you coming to the office, it could be $75, could be $100. Tell them your fee. Now, I'm not going to charge somebody a teledentistry fee if they're my patient and they need a temporary put in and they want to talk to me. No, of course I'm not charging them. I'm more so talking about new patients who've come back to your office that you haven't seen in 5 years, and now they have an emergency. You should be billing for your time. Just be upfront about this. And tell them what to expect in your video. Tell them what to expect as far as some of the new protocols and why your office is great, what you're stepping up to. And then tell them the path. Tell them the path leading forward is challenging. You know, a lot of people are unemployed. Tell them you've been unemployed. Tell them about your in-office new dental savings plans. Tell them about your low interest financing plans. I mean, one of my associates sees, one PPO. I can tell you, PPOs aren't going to raise their fees and offer PPE reimbursements. They're not going to be in my practice. No way am I seeing PPO patients that aren't going to be compensating me for the additional time in PPEs. So as I close, here's my summary. Set up a screening protocol. If you want it, call Tim. I'll forward this to Tim. Set up your own if you think mine's too crazy. I don't think it is. You want to send this out and have a written signature, and then you're going to follow it up with a verbal or visual follow-up. You're going to select the appropriate test or test for each patient. You're going to test yourselves. You may be testing yourselves every week. You may, and again, I would send an email to your patients about your protocols. I would have a link to a video. I would definitely set up a PPE fee, and I really believe in where we're going with teledentistry. Why not? It's a very minimum investment. You can join me. I have a great vlog. It's called The New Norm. You can find it at midwayedu.com or at catapulteducation.com. We've done 20 episodes. We do about 4 or 5 a week, and we are cutting edge, no doubt about it. We bring in experts from all over the country on how to deal with this virus, both on a OSHA level, technology level, business level, legal level, and all that goes on over and really what's going to go on for the next, I think, 2 to 3 months. And then we'll see what the new norm is after that. As I end this, I just want to say, this is my personal email. It's lou@catapulteducation.com. All I ask you to do is be safe and be smart. Dentistry strong. Thank you for participating, and I hope you enjoyed this presentation. Thank you.
Dr. Graham, great job. I appreciate you doing this for all the doctors out there. Again, if you have any questions, reach out to Dr. Graham at lou@catapulteducation.com. You can also reach out to me at tmalding@prexion.com. So last thing, Dr. Graham, I appreciate you doing this on behalf of Catapult Education and PreXion CBCT.
Thank you, Tim. Thank you.